Hi everyone, my name's Will Jenner. I'm one of the cardiology and GIM registrars here at Lister Hospital.
Hello everyone, my name is Mio. I'm one of the cardiology and GM registrars here in Lister Hospital as well. So I'd like to express my thanks to Joe and TJ for inviting us to this COVID-19 Lister webinar, and also express my special thanks to Dr. Dubovitz, cardiology consultant here, for agreeing to have a look at our presentation and give useful advice.
So today we're going to be talking about COVID-19 cardiology as part of the webinars that TJ and Joe have organised. So just an overview of what we're going to talk about. So first of all, about cardiovascular disease as a risk factor for COVID-19. We're going to then talk about ACE inhibitors and ARBs. We're going to talk about cardiac injury. We're going to talk about COVID-19 related myocarditis and arrhythmias. And finally, about novel therapies and some cautions. So for the majority of people that develop COVID-19, they have mild symptoms, or we suspect a significant proportion are asymptomatic completely. But given that it's a global pandemic, a significant number of patients have developed the more severe symptoms, which has included a pneumonitis and predominantly patients becoming more unwell and going into respiratory failure. But we know that this is also having quite a significant effect on cardiology and cardiology patients. So firstly, because cardiovascular disease seems to be an important risk factor for patients who develop the more severe form of COVID-19, which we'll discuss in a little bit. Also because patients who have severe COVID-19 also seem to develop a cardiac injury, again, which we'll go into in more detail. There's also concerns that have about diagnostic bias, and by that I mean patients who are presenting with alternative diagnoses, which might include acute heart failure, who are being labelled initially as COVID-19 and actually not receiving the appropriate treatment for the condition that they actually have. And this is something that has been reported, but there isn't a huge amount of data available as to how many patients this is actually affecting. But what there is evidence for now is that there is a significant national reduction in the number of patients who are presenting with heart attack each day, which usually nationally is about 300 patients, and there seems to be about a 50% reduction in that, and that's been reduced over the course of March as the global pandemic has affected the UK. The British Heart Foundation in particular has put out information about this in the last few days to say that it is really important that patients who have severe chest pain or have other features of heart attack must come to hospital and seek medical advice. We also know that the global pandemic is having a significant effect on cardiology services, which has included postponing some of the non-urgent services, including imaging and some of the therapeutic options that are available for patients. There's also a lot more in the way of virtual clinics taking place compared to what there would have been previously. But also that cardiology services are affected because the doctors who take part, who are involved, doctors and other staff who are involved with cardiology are also frontline staff and are likely to be called to provide their assistance elsewhere, or actually may have been affected by the virus themselves and therefore not be able to be working as they would do normally.
So first of all, we would like to talk about cardiovascular risk factors for adverse outcomes in COVID-19. So it has been reported that patients with hypertension, diabetes, and underlying coronary artery disease and cerebrovascular disease are prone to have, likely to have COVID-19 infection, and they're more likely to have severe and fatal infection. So as you can see from these studies from China, roughly 20 to 30% of patients had hypertension, and up to 22% had diabetes and cerebrovascular disease. But the reason behind why these patients are more likely to have adverse outcomes still unclear. There are many proposed theories, including increased cellular expression of angiotensin converting enzyme 2, and which is going to be discussed by Will in the next slide.
So a few weeks ago, there was quite a lot of concern raised about the use of angiotensin converting enzyme inhibitors, ACE inhibitors, angiotensin receptor blockers, ARBs. And this really came about from the sort of mechanism which showed that SARS-CoV enters the cells after binding to the ACE2 receptor, which is expressed in many places in the body, in particular the heart and the lungs, but also vascular endothelium and elsewhere. So there was also, we also know from previous work that if you're on an ACE inhibitor or an ARB, that you're more likely to express high levels of ACE2. So that's sort of where the concern came about. But there wasn't any, medical or scientific evidence to show that this was the case, and that patients with on ACE inhibitors, ARBs, were more likely to develop COVID-19 or more likely to become more unwell if they did get COVID-19. But because of this initial mechanistic theory, there was became widespread concerns, and in particular information being shared on social media rather than in the medical literature. And it was, but there was nothing to support this, and there was nothing to suggest that ACE inhibitors or ARBs should be discontinued. But because of this information that was being shared on social media, the number of medical societies put out information. So European Society of Cardiology, the Council of Hypertension, or the ESC, put out this information where they said that strongly recommend that physicians and patients should continue treatment with their usual antihypertensive therapy, because there is no clinical or scientific evidence to suggest that that treatment with ACE inhibitors or ARBs should be discontinued because of the COVID-19 infection. And this was supported by the additional bodies listed here as well.
So the next important thing we need to think about is the high troponin level in COVID-19. So the reported frequency about high troponin level in these patients is quite variable. It could be anywhere from 7% to 20%. And I think it's quite common in these patients, particularly as we're using high sensitivity troponin assay these days.
And in particular in the patients that have been admitted that are unwell. So
exactly. Mm-hmm. So if we look at the data here from China, out of 191 patients in Wuhan, 54 non-survivors had a mean troponin value of 22.2, and 137 survivors had a troponin value of 3. Another study showed out of 416 patients, up to 82%, which is nearly 20%, has high troponin I. And it has been shown that these patients have higher mortality, which is as high as 50% at 30 days. So they had some sort of myocardial injury. So what they found is that compared with without patients without myocardial injury, these patients are more likely to be older and have more comorbidities and greater lab abnormalities like high CRP and other things like impaired liver function, impaired kidney function, and they are more likely to be sicker, and like their lung imaging quite bad. So for some reason, they are more likely to require non-invasive or invasive ventilations. So basically, they got more complications. So if we need to think about why the troponin level is high in these patients, we need to sit back and look at the mechanism and spectrum of myocardial injury. So on one end, we've got normal myocardium, there's no injury. And if we reach this area, there is a degree of myocardial injury, which is evident by a tropoleak, basically increased troponin level. If there is a rise or a fall of troponin level, we call this acute. So acute myocardial injury. So if things are getting worse, if there's insults ongoing, we will reach to a point where the clinically evident myocardial ischemia will be apparent in terms of clinical features such as anginal or anginal equivalent symptoms or ECG changes or imaging evident. And at this stage, we call it myocardial infarction. So basically, there are quite a few things that could potentially cause all of these injury, including anemia, ventricular tachycardia, heart failure, hypoxia, shock, kidney disease. So what actually caused the trop leak in COVID-19? Well, any one of those could potentially cause the troponin rise in these patients, and so do systemic inflammatory response and direct inflammatory issue in the heart. But it may well be a combination of one of or more of all of these above, or it could be more reason, but we don't actually know the reason.
So I think it's important to say that, you know, we're putting theories together here, but
yes.
You know, we don't know for certain, and actually, you know, until more people do sort of more advanced imaging or more biopsies on patients who have been severely unwell, it's very difficult for us to say for certain exactly what's available and what the cause is.
Yeah, so the bottom line, there might be some sort of acute myocardial injury, but we don't know the actual reason. So one important theory might be the myocarditis, which you're going to talk about later as well. So more importantly, what do we need to do about the trop rise? And the answer is just we need to go back to basics. If there's no evidence of clinical evidence of myocardial ischemia, like relevant history, relevant ECG changes, or imaging evidence, we don't actually need to act on it. And there's no current evidence for antithrombotic or anticoagulant therapy for acute myocardial injury, unless we suspect plaque rupture in type 1 myocardial infarction.
Okay. So there has been quite a lot of initial discussion about whether COVID-19 causes a myocarditis. So when we're talking about myocarditis, what we're talking about is patients who come in with symptoms such as chest pain, shortness of breath, arrhythmias, or shock, and who have abnormal investigations such as an abnormal ECG, an elevated troponin, or abnormal imaging, so structural imaging such as echo, CT, or cardiac MRI. But as we know, this is really difficult to be specific about this because these symptoms are quite broad. They could be seen with COVID anyway, and we've seen patients who present with chest pain with COVID, and we also know that you know, patients who are severely unwell with COVID can develop shock, they can develop arrhythmias, and shortness of breath is one of the most common symptoms that's there. And again, the abnormalities in the investigations can also be seen in critical illness for the reasons that we've already explained. So we don't really know what's happening in the heart of these patients. And to do that, we need imaging or biopsy. So what would be useful would be for some papers to explain this. And there are some papers. So the first paper is a case report from Italy. It's one 53-year-old female who has confirmed COVID. She presented to an Italian hospital after 2 days of severe fatigue, but with no chest pain and no shortness of breath. She did have fever and she had had a cough for a week. Her initial ECG showed widespread ST elevation, an elevated troponin, a raised BNP, and she had an echo, which showed some regional wall motion abnormalities. And so she underwent an angiogram, which showed that she had unobstructed coronaries. Patient then went on after a few days and after recovering to have a cardiac MRI. And the images are here, but essentially what this shows is a diffuse biventricular hypokinesis. It shows severe LV dysfunction. It shows marked biventricular interstitial edema and late gadolinium enhancement. But what it didn't have was a biopsy. And so what we don't really know is what was actually happening at a cellular level. But this would sort of initially fit with somebody with myocarditis in a more typical sense.
So this one's an interesting paper, and which is also from Italy. So we've got this 43-year-old lady who essentially came in with fever, shortness of breath, hypoxia, and chest pain, and her COVID swab came back as positive, and they found there's slight ST elevation in V2, V3, and AV with some reciprocal changes in ECG, and they didn't drop, and there was a delta change in drop level, and they also did echocardiogram and found some sort of infralateral hypokinesia with mildly reduced ejection fraction. And the initial impression was possible viral myocarditis, but they also did CT coronary angiogram to rule out any underlying coronary heart disease, and found out that her coronaries are clear. She then went into have cardiac MRI, which essentially showed diffuse myocardial edema with the same regional wall motion abnormalities on echo, but there's no myocardial scarring on late gadolinium enhancement. And they also performed endomyocardial biopsy in this case, and it showed diffuse T-cell infiltrates with marked interstitial edema with foci of necrosis, which is not typical of ischemic myocardial injury. So there is no fibrosis, meaning that there's ongoing acute inflammatory process. Unfortunately, the molecular analysis failed to show COVID-19 genome. So it's really worth mentioning in this case that so COVID-19 is not a known cardiotropic virus, and they did not look for, here in this case, they did not look for other known cardiotropic viruses such as enterovirus or parvovirus B19. And what we think is that if we need to label COVID-19 as a novel cause of myocarditis, we need biopsy evidence, which is the lymphocytic infiltrates with necrosis, and we need positive genome sequence of COVID-19 in cells. So essentially, we're still waiting for biopsy and autopsy proven myocarditis case report here.
Yeah. So the answer is possible that COVID-19 might cause a myocarditis,
yes,
but
exactly.
we've only got 2 case reports in the current literature to support that. So really quite limited at the moment. But it's likely that in the next few weeks and months that that we'll get much more answers.
There's also another
more definitive with that.
Paper in if you're interested, you can have a look in ESC. There's 17 or 21-year-old girl with myocarditis, and we can share the link later if you want. Okay. So the next bit is about arrhythmia in COVID-19, and to be honest, majority of COVID-19 patients, they will not have symptoms or signs of arrhythmia or any conduction system disease, but some studies from China show that roughly 7% presented with palpitations and initial symptoms, and mainly as same as in other critically ill patients, nearly half of ICU patients had some sort of arrhythmia, and 70% in general cohort, and they found that the most likely cause of tachycardia, sinus tachycardia, and same as other respiratory infection, it can cause atrial tachyarrhythmia, like atrial flutter fibrillation, and also ventricular tachycardia, including and we're going to mention about Torsad and relevance here in COVID-19 later. So the question is, do we need to monitor ECG continuously in this patient? And the answer is, it's not really necessary unless there are other standard indications, like if we suspect myocardial infarction, or if there's any electrolyte disturbance.
Yeah, or if they're critically ill for other reasons,
yes.
or where you would want to have somebody on ECG monitoring. Okay, so the next thing to talk about is about long QT syndrome. And this is in reference to some of the medications that are being trialled for COVID-19. So QTc is prolonged, strictly speaking, prolonged in men if it's greater than 440 milliseconds, or in women if it's greater than 460 milliseconds. And why do we get concerned about long QT? Well, because it's associated with ventricular arrhythmias, including torsades de pointes. And this is an example of an ECG, which shows a long QTc of 510 milliseconds, and in this case was secondary to hypocalcemia.
So this is just to refresh your mind a bit about things that could potentially prolong QT interval. I'm sure you're well aware of that. Particularly important is all the electrolytes, low potassium, magnesium, calcium, and just, to make sure they're not on these medications like tricyclic antidepressant, SSRIs, chloroquine, and also antibiotics, including some macrolides. So why is it relevant in COVID-19?
Well, it's relevant because here at Lister Hospital and actually across the UK in a number of trusts, they're going to be recruiting for the recovery trial. The recovery trial has 5 different arms to it, or 4 different trial drugs that are going to be sort of used to experimentally to see whether they work against COVID-19. 4 different drugs at the moment and 1 control. But 2 of the drugs that are going to be used are going to be hydroxychloroquine and azithromycin. And in both of these medications, one of the cautions is for long QTc. And that's because historically there have been some case reports for each of these medications that shows that they can be associated with long QT, and that they can theoretically be associated with ventricular arrhythmias. Again, these are medications that are very commonly used for lupus with hydroxychloroquine, or as an antibiotic for azithromycin. But actually, the likelihood of developing long QT normally from these medications is very, very rare. So actually, if you're on these medications, normally you wouldn't be having routine ECG follow-ups to check to see. But we do have to be quite cautious because they are both contraindicated if you have long QT. And we have to be cautious about in these patients about if you're starting additional medications that could also prolong the QT. And in patients that are severely unwell from COVID-19, they could be on some of the additional medications that we've already alluded to that might prolong the QT. Or they may actually have been already started on medications that could prolong the QT, and then that could be, in theory, exacerbated by starting on hydroxychloroquine or azithromycin. So there's a few bits of advice that I think it's worth mentioning. First of all, before starting on the medication, it's important to have a look to see whether there are any available ECGs for the patients. Most of the patients that will be starting for this trial will be doing so in hospital, and so they are likely to already have an ECG available, in which case it would be sensible to review that to see whether it shows that whether they have long QT or not. And then if you review their ECG and you see that they have QTc that's greater than 500, then you should consider avoiding potential QTc prolonging agents. And this is something that's been highlighted in a paper or in a correspondence in JAC from last week from the heads of the AHA, the ACC, the HRS, so 3 of the big American cardiac societies, to basically say just be cautious in these patients. If you can, check some follow-up QTCs where feasible, but accepting that you don't want to put healthcare workers at risk of developing COVID-19 if they're having to do additional ECGs. They also explain the importance of correcting electrolytes, and as we've already said, hypomagnesemia and hypokalemia are common causes of long QT. So actually, if you can correct those, then that would reduce your risk as well. And as we said, once you've started on one of these medications, where feasible, trying to avoid additional agents that might prolong the QT. Okay. So we've been through quite a lot of information in this talk today. So what probably has come across is actually very little is understood about the cardiac effects of COVID-19. And every day more and more papers are being published, and our understanding of it is developing each day. So really what we've said in this talk is what we understand at the moment, but we accept that in the next few days and weeks and months that actually our knowledge is going to as a cardiology community is going to develop significantly. We also have to be cautious that a little rumour can go a long way, and that was really shown with about ACE inhibitors, how one suggestion suddenly became a widespread share on WhatsApp and on other social media. So it's something that has to be very, very cautious about sort of information that's said. We also have to be very careful about COVID-19 bias, and in particular when you're thinking about other causes why someone might present with breathlessness or with chest pain. And in particular, patients presenting with cardiac disease such as acute or subacute heart failure, who may present in very similar ways with very similar appearances clinically and on chest x-ray to patients with COVID-19. But importantly, don't forget the basics. So if you're seeing someone who's got ST elevation on their ECG, you should be getting in touch with your local primary PCI centre or calling the cardiology registrar as a matter of urgency. If you're seeing patients that have got a significantly elevated troponin that you're worried about, then you should be speaking to the cardiology registrar. And here at Lister, we have a 24-hour cardiology registrar available.
Yeah, it's also in ED 24-hour, not just for ward. So if any issues, any doubts, just ask us. That's why we're here.
Yeah, absolutely. So we're here to help and to provide support wherever it's needed. And we know that these are very challenging times, and we've adapted our service to be able to support that as well.
So as we've mentioned, what we've talked through here might not be relevant in the next couple of weeks, but we'll keep an eye out for any new evidence and things, and we will keep you updated.
Absolutely. So these are our email addresses. So please don't hesitate to send us any questions that you might have or provide any feedback for this talk. That'd be really appreciated.
Yeah, we're going to be grateful and hope you'll enjoy the video.
And once again, thanks to everyone who's helped us to put this together.
Thank you.